As many of our audience may know, the Epilepsy Foundation of Michigan's Challenge of the Year for 2021 is supporting caregivers. So for this session, we're going to do just that by discussing resources and strategies to help caregivers coordinate medical care for their loved ones with epilepsy, support epilepsy self-management and self-determination, and coordinate a wide array of supportive services across the lifespan. So let's start by having each of you share a little bit about your background and your experience with this topic. Dr. Tang, would you like to start?
Sure. Can you all hear me?
Yeah.
So I started my career after college really in the basic sciences with epilepsy. I worked at NIH for a couple years and then at the University of Maryland Medical School. When I started medical school, I primarily trained in the US, but I did do a little bit of work in the UK studying pediatrics. I did my residency at Virginia Commonwealth University in Richmond, Virginia, and then University of Michigan for my epilepsy fellowship. After that, I moved to Grand Rapids, Michigan, where I work at Mercy Health. And I work in the adult epilepsy group, and I see patients ranging from independent adults to those in managed care facilities. I have worked with pediatric and adult epilepsy patients throughout my training, however, and I have participated in some research on transition readiness during my fellowship.
Yeah, thank you, Dr. Tang, for sharing that. And Nick and Joan, if you want to just share a little bit about your background and your experience.
So sharing our background?
Yeah.
Okay. Nick and I are parents of a 30-year-old son with epilepsy. He had his first seizure at age 6 months. He's 30 now, and he has had grand mal or tonic-clonic seizures throughout his life. As a result, he is also cognitively impaired. He's our third child. We have 4 children. And you want to jump in?
I actually a little bit more about our background. We've been together for 38 years now, and Alex, as Joe mentioned, is our third child, and we did have a 4th child afterwards. It has been a little bit challenging, as Alex had his first seizures when he was young, but he had a significantly two long seizures when he was about 3-4 years old, and that left him cognitively impaired. They were like 35-minute long seizures. And as a result, we've had to provide him his care throughout his life.
Okay, great. Well, thank you for sharing that. And we, again, look forward to hearing more about your experiences. And Hannah.
Hi, good afternoon. I'm Hannah, and I'm the spouse of a person with epilepsy, my husband, Mark Stegink. And I'd like to start off just distinguishing my role as caregiver to one who cares and not a caretaker. As a spouse, that's especially important to me, so that our relationship be interdependent. And Mark provides care to me and I provide care to him. So his seizures started when he was around 7 years old, and they were discovered by his sister, who he kicked during sleep while camping. So his seizures are unique in that they are occurring in his sleep cycle, and they allow him to be in a relatively safe space, so they don't occur during the day. Exception being when he's fallen out of bed, and they used to occur 6 to 8 times a night, pretty violently. They would wake him from sleep, cause challenges with getting sleep, understandably. And then it was diagnosed as a sleep disorder until about 2012 or 13. So around the time when we started dating, there was better technology and information and testing procedures. So he pursued a diagnosis of epilepsy, specifically the focal impaired awareness, or what's used to be known as complex partial seizures. And so, yeah, that's been part of my experience. He went through a brain surgery and had a neuropace planted, so that pretty significant part of our story. And when I talk about caregiving, it's just in terms of helping support him to function as a separate being with his own interests and make his own decisions. That does look a little bit different than maybe other spouses, in that his seizures have caused challenges with some cognitive functioning and executive functioning. So just like understanding things and processing takes an extra step. He'll get there and he does great. So we have to be a little bit creative in our approach. Thank you.
Okay, great. You brought up a lot of great points that we'll dive into further. So thank you, everyone. So, so in addition to a neurologist and primary care physician, people with epilepsy may need to see a number of other healthcare professionals, and effective communication between these providers is crucial. Dr. Tang, what protocols are in place in the healthcare system to help clinicians reliably exchange essential patient information? And what are the most important things that patients and caregivers can do to facilitate communication and coordination of care?
This is actually a very big topic. I'll start with the mechanisms that are in place. You know, the medical profession, like most other professions over the last decade or so, has been able to move more towards using electronic documentation and communication almost exclusively, which does make information more easily accessible, and, you know, sometimes more legible, if you like the joke about doctor handwriting. But unfortunately, if different providers aren't within the same health system or aren't on the same electronic record system, patients' information still often has to be faxed, physically transferred, like paper between providers, or even directly communicated verbally between patient, caregiver, or between providers. So, you know, while we're moving forward, we still have some things back from the last century. You know, another thing that is a barrier is that some providers' input isn't always accessible to those seeking that communication. Doctors retire kind of unexpectedly sometimes they switch practice, or sometimes records can be kind of terminally archived and hard to retrieve. Additionally, when patients transfer between different providers, you know, the previous physician could be so familiar with that patient that they haven't documented a lot of key aspects of the patient's condition in years. So, you know, there are a lot of challenges with communications, and trying to get each provider to forward relevant documents to other providers is very important. You know, so as doctors, we're really working on improving that still. But from the caregiver and the patient can do a lot on their own to help us. And mainly this is trying to keep your own records as backup. And this can be really overwhelming. There's a massive amount of information that's being generated from for a patient. You know, even one clinic visit can generate maybe 5-10 pages of electronic paperwork, and it can be impossible to sort through on your own sometimes. You know, to help filter this information, you can ask your provider to write out a short summary after a visit of what you talked about and the key points moving forward. You can maintain your own archive, including important diagnostic tests that have been done, like EEG results, MRI results, imaging, drug levels, and then important milestones in, you know, the progress. This can include the age seizures started, description of seizures, meds tried, and reactions to those, any surgeries. On the other hand, keeping too many details can be unhelpful and actually can lead to frustration. You know, having a stack of paper this tall doesn't really help anybody. So you can work with your providers to figure out what is the most important information to keep.
Great. And other comments from our other panelists? Anything you wanted to share?
You know, I'm seeing some of the comments on the chat too. One of the key things that, you know, I'll give credit to Joan, is she started a journal right at the get-go, and you know, with Alex being 30, you know, previous century, was keeping track of everything that happened with him at home, what types of seizures, what types of medications. For us, we ended up relocating from Michigan to New Jersey for a period of time. So not only did we, leave the health system, but we also went into a totally different hospital environment. And those documents had to be transferred at the time. With the electronic systems now, it's better. But again, keeping that information in that journal was critical for us, because it's like starting back over, and you can have the specific dates, the specific medications, when they were given, and what worked, what didn't work. And I think that definitely helps a great deal.
Right, and I'd like to add, Dr. Tang, you are spot on as far as we need to keep records. And, the turnover in Alex's neurologist has been, due to moving or divorce or whatever. We had a long-term one we loved, and he moved on. And then as you're going through life, and we have reached out recently to the Epilepsy Foundation, and I thank Russ for this, to find a good neurologist. And again, you have to inform them of, the records you have. And this neurologist is very thorough, although she doesn't know Alex. He's 30 now, so it's about keeping records. And my biggest thing raising a child with epilepsy is three things: educate, educate, educate. And that's educate everyone he will ever be in contact with, because we're his best advocate. And they're going to help us, but, we have a role to play too, to get the help we need.
Really important point. Yeah. Hannah, any last thoughts?
Only to say, keep the records in one place, and chronological is very helpful.
Right. So Dr. Tang, can you describe the spectrum of both access to patient information and also involvement in healthcare decisions that caregivers can have? And how do you decide where on that spectrum is appropriate, and how do you go about obtaining that level of access and involvement?
I think in some ways this is sort of a continuation of the previous topic, because sometimes it's hard to access all the information and communication that you would like to have. But, I agree, ability to communicate is one of the most important parts of helping your provider decide on management options to give to you to think about. And then to decide how much you want to participate with that. And, in terms of the amount of involvement the caregiver has versus the patient themselves has in their care, really should depend on how much the patient is able to understand about their epilepsy and follow through independently with a management plan, which is a whole nother topic. But, I think there's two parts to it, and how much you want to dictate what the provider does and how much you want the patient to keep track to be independent. If that answers the question.
And Joan and Nick, how did you kind of come about that decision of what level of involvement and in decision making you had with Alex?
Well, I think our situation's a little bit different, because we are totally involved in his health care, because he is cognitively impaired as well, as a result of many grand mal tonic-clonic seizures in childhood. So we are his best advocates, and we're totally involved in his caregiving and his decisions.
Yeah. I mean, even from giving him his medications, we need to make sure he's taking them as prescribed in the right amounts. Obviously, as he has picked, he knows, for example, that if we're going to give him his medication, and or he reminds us at times also, but we are there to give him the medication to make sure he's getting the doctor visits, that he's keeping up with not only his neurologist visits, but also his regular pediatrician and regular doctor, make sure he's getting his tests and his immunizations and all that kind of thing. So we're still heavily involved in his day-to-day caregiving.
And can you talk just briefly about kind of the legal aspects? Do you have guardianship? Is there like power of attorney or any of those types of things?
So yes, we had power of attorney. I'm trying to remember how many years ago it was, but through the ARC, we actually, the seminars that were given in the area through the school district that he was in, They had specific seminars about, caregiving and after you're gone programs, that kind of thing. And
Trust and will.
Trust and wills, as well as, like you mentioned about the power of attorney. We tried to give him as much authority from a decision-making standpoint. So we didn't go through guardianship. We were going the route of power of attorney. And that's been successful for us.
Great. Hannah, how did you come about how did you and Mark decide upon the level of decision-making and access to information?
Sure. So I would say that currently the level of involvement I have in his health decisions is none. Specifically, he makes his own decisions. We actually talked about this recently, and he said, "You don't have any say in my healthcare decisions." Right. So we talk about it together. I don't attend appointments. I used to do that because I wanted to learn about his epilepsy. I wanted to understand what was going on and how I could best support him. Part of that decision is influenced by the fact that he's 5 years post-op. So he had the NeuroPace, and that made a huge difference in his seizures. So whereas I mentioned before, he was having 6 to 8 per night violent seizures that would wake him up, he is now having, I couldn't tell you how many for sure, because I don't sense them. I sleep through them. I used to duck and roll. So yeah, it's maybe every other night, maybe every night. We'd have to look at the data from the NeuroPace itself. So it does a very good job in kind of like a defibrillator and kind of ending the seizure activity before it happens, which is really great. It's also when they do happen, they're less intense. So they're less frequent and less intense. So there's not as many decisions that are being made at this point. So that definitely influences it. We had lots of conversations around the time he had his surgery. I am definitely more of the detail focused person in our relationship. And so I did a lot of the research on epilepsy centers, neurologists, and things like that. And he did say that that was very helpful. The most supportive help that Mark said I provide is encouragement, standing back and letting him make decisions, believing in him that he's capable of doing that, and just helping him understand what's being said if there's questions, but letting him generate those questions. And so trying to take a backseat supportive role, which was challenging for me. I like to caretake. So.
Right. So I'm sorry, there's a little bit of background noise. I hope you can hear. Next question I wanted to talk about is transition from pediatric to adult epilepsy care is a long process that's largely handled on the pediatric side, but adult neurologists also play a role. Dr. Tang, what do you see as some of the keys to successful healthcare transition?
A lot of the transition from pediatric to adult care is at least partially dependent on where they are cognitively. Obviously that's spectrum in itself. But there are people that may not truly transition to what we normally consider as independent adult care. But for the people that are able to, there are several factors that most people would agree on. From my perspective, my experience, I would say that early in the teens, if possible, again, the patients and their caregivers should begin working on having the patient know the names of their meds, about them as much as they can comprehend. Try to take them independently as best they can. There's a lot of devices now. Everyone seems to have a cell phone. And even initiate refilling them as best they can and as independently as they can. Being comfortable talking about the medications with the parents, with doctors, and how they make them feel is important. All that, the communication between the patient and the caregiver is important to foster. I would say later, sometime after that, the physician and their team can emphasize that they'd really like to speak to the patient mostly during the clinic visits, if possible. as much as they're able to communicate, and have the caregiver fill in gaps only if needed. And then I think there's a few really overlooked parts, and they're very important parts of transitioning that I think don't get talked about enough, because I've seen it a lot in my clinic, are reproductive health, understanding the effects of drug and alcohol use in the adolescent and young adult population, and sleep deprivation that comes particularly if they want to go to college and they want to be independent. And I think these are overlooked, partially because there's some discomfort with talking about these topics. Either the parents, the kids think that their parents don't want to know things that they're doing, or the parents don't necessarily believe that the kid would do anything, like how, date or drink alcohol. But allowing the patients to speak freely as best as they can is helpful, and even maybe without the caregiver present at times, to allow them to speak more freely. As a patient gets closer to kind of that cutoff at 18 to 20 years old, I think a more formal assessment of readiness could be done. There are some transition surveys that are used somewhat widely among the medical community. A family could even find one of these surveys online, go through it, come up with some of the topics that maybe aren't accounted for in their patient, and then choose to talk about those when they visit their doctor. It's actually an ongoing interest throughout the research, the epilepsy field, because it's been shown that these transitions, really a lack of a good transition can lead to unnecessarily poor seizure control, even SUDEP, or sudden unexplained death in epilepsy, and some increased social isolation.
Right, and what about that actual transfer of care when you go from pediatric to adult neurologist? Is there anything that can kind of help that be a warm handoff, I guess? More smoothly?
Ideally, the suggestion is that the pediatric neurologist or pediatrician allow the patient to see the adult neurologist once, is kind of to put their foot in the water, and then kind of come back to the pediatrician and give them some feedback. I have to say, I don't think that I've actually seen this happen in practice yet.
Yeah, and unfortunately, I think insurance can sometimes be a barrier to having both have a mutual appointment where you're with both the pediatric and adult neurologist. So that would be certainly helpful, but I know insurance can sometimes be a barrier to that. So Nick and Joan, what can you talk about Alex's transition from pediatric neurologist to adult, and how you manage that?
Okay, so basically for Alex, he sees a pediatrician, as did all my children, and and then we found him a neurologist. So right now they're kind of hand in hand for us, because he's mentally challenged. He still does see his pediatrician, and because he's very thorough with him and he knows Alex, and we had said at one point, should we transition him to Nick's, my husband's doctor? This is your general practitioner, I'll say. And our pediatrician agrees to continue seeing him, and we work hand in hand with the neurologist. And as Dr. Tang said, it's about keeping records, keeping, everybody on top of everything. He does see an adult neurologist now that he's an adult, as far as his medications and things, because he is mentally challenged. We do try to include him, especially when we're switching drugs or trying to find a new seizure medication for him. How does this make you feel, Alex? And just being his best advocate and seeing the changes in him. And I'll give you an example. One time he was having many, many, many seizures, and they put him on a drug, can't recall the name. And it also, it started to control the seizures, but honestly, he was like he was a zombie laying on the couch. And my neurologist at the time said, well, but he's not seizing. And I came back as his advocate but he has no quality of life right now. So it's about finding the best fit, because you're your loved one's best advocate, and it's about finding the best fit for him. So we continue to search for somebody that would help us. And, through the years, we've gotten the best control we have as far as, because he was having many seizures a day, and now I'll say maybe he has 1 or 2 a month. So we are his best advocate, and it's about if it's not working here, then let's find something that will work.
I think one of the key things, you had mentioned is about the transfer of people. And we've had, since we moved to, New Jersey and came back, we had a great neurologist here, but he left the practice or the system he was in, went to another system. And at that point in time, we kind of, I'll say, fell through the cracks. We had a nurse practitioner that had a background in neurology, and I'll say we saw her a couple of times, but we really wanted a neurologist for Alex. So, she recommended somebody, but that person didn't have a background in epilepsy, didn't have experience or a focus in epilepsy. And that's, Russ, you recall, that's when we reached out to you and said, we need somebody that has that, because we felt like we were informing her about epilepsy, and so then we did, thanks to your help, we ended up finding somebody that has that specialty, that background, and, made sure that he went back and had an updated EEG and some other tests that she said that he hasn't had that in his records, and recommended that we do that. So it is key to make sure that you have that person with a specialty in epilepsy, a neurologist with that specialty. So that's the experience that we've had, going through life with Alex.
Great. And Hannah, Mark developed epilepsy as a child, so he went through the transition process. What have you learned about that process that was helpful to share?
Sure. So I know that Mark's parents could probably speak better to the question of transitioning from pediatric to adult epilepsy. At the same time, when he was a kid, the diagnosis was a sleep disorder. So he had a neurologist because it was a sleep disorder with seizures. He actually didn't have an epileptic pediatric care per se. So when I came on the scene, I was like, what is this epilepsy? Like, tell me about it. And is there any new tests? So that's kind of where he transitioned on his own to adult epilepsy specialist at Spectrum Health. I think the biggest transition from being a person with epilepsy as a child to being a person with epilepsy as an adult, and being married, particularly was the most significant. So particularly because of some of the neurocognitive challenges. So he has intelligence is fine, and he can process and understand things. But when we were dating, I said, hey, let's do some neurocognitive testing. Like, I kind of want to know all about you and what I'm getting into potentially. He had some questions for me too, but I'm looking for my notes here just a bit. So the doctor there, Dr. Bertram, had recommended that someone review important decisions to make sure he's accurately accounted for important available information. And then also in emergency or stressful situations that he consult with others when dealing with complex decision-making, knowing that the approach might be narrow or perseverative, it might not spontaneously generate multiple options. So problem solving, particularly in short, is really challenging. And so the suggested accommodations were like queuing to conduct brainstorming activities and aid him in evaluating pros and cons. That's right from the report. As a wife, that's challenging because I have my own ideas and perspectives about how things should go, and to maintain a healthy relationship with someone who is higher functioning, but has challenges. It's a balance of being able to maintain and express my own preferences while also providing him with some of that information so that he can understand it and make an informed decision. So it can be challenging. That's probably the biggest area where we've had to be creative and allow our marriage to look a little different than others.
And that flows right into our next question. With epilepsy being a spectrum disorder, an individual's seizure frequency, their cognitive abilities, and other disabilities kind of help determine the extent to which that individual can manage their own condition and the amount of caregiver assistance they might need. So Hannah, you talked about on the kind of cognitive side of things, the role that you play in assisting with day-to-day management of epilepsy and decisions and things along those lines. Nick and Joan, and you've kind of also referenced kind of the role that you play in terms of medication adherence. What are some things that Alex is able to do with less assistance, and what things require more assistance, and how have you kind of come to that balance of providing assistance and allowing him to do things that he's capable of doing?
Well, I think that as he was young, we learned his limits and what sets him off, I'll say, from having seizures. And I'll say, based on experience, right? So if overheating caused him to have seizures, then obviously we try to minimize him from getting overexerted and that type of thing. And then we learned later on his anxiety of, I'll say, walking, or if something happens with his footing, that can set him off. And that's what we've learned actually lately, is that if he's standing there and somebody was to push him, that would set him off into a seizure. So as Joan mentioned, you have to educate people around him that you can't, I'll say, play or horseplay with Alex, because that can actually set him off into a seizure. And there's times when he knows that, because he will say, hey, that person was going to do so, that person tried doing that, which will cause me to have a seizure. So he himself learns that, and he knows that his limitations, and from a walking standpoint and his balance, that type of thing. And you can see he's very cautious. He'll reach out maybe for assistance to help him so he doesn't lose his footing or whatever. People look at me, I probably have the cleanest, driest driveway in the winter in Michigan, because I want to make sure that nothing will happen if he goes out and slips, because that slip will cause him to have a seizure. So you learn those, you have those experiences, you learn from that, and you make sure that you prevent that from happening, because nobody wants to see somebody have a seizure. So it's those experiences that you learn through and grow with him as he grows. Yes,
and we make sure he gets 10 to 12 hours of sleep at night, avoid the stress, stick to a daily routine for him. And again, like Hannah said, in her marriage, it's challenging. It's challenging for us as parents. We're both retired now, and we joke and say it's the Broggi party of three, because we have Alex, and, we want to take him to a wedding, a family wedding, that's fine, but he needs to sleep. So it is a challenging, very challenging situation, but we manage it to the best of our ability to give him a wonderful life, I'll say, and for us to enjoy life too.
One brief example, we recently went to Disney World, and friends that were with us, we wanted to do a ride, the Pandora ride. That's something that she really wanted to do. And our friend said, Alex can't do that ride. And we said, well, why do you say that? Well, you got to sit on this bike. But when we went there, and we showed him a video. We were actually able to see the video. And Alex, do you want to do this? Yes, he wanted to do it. Got him on the ride, took it. He loved it. He actually wanted to go back a second time. There was another ride when we went a couple of years ago to Universal. Alex, you want to do this ride? He looked at what it took to sit in it. No, I don't want to do it. Why? Because again, through one of our experiences at a ride, if it's something where footing wise and he has to get in, it will actually potentially cause him to have a seizure. And he actually did on one ride years ago. And that's why we really are careful. But at the same time, we want him to enjoy life and experience life.
Right.
So he kind of knows his limits. We know his limits, and we
teach other his limits.
Yeah.
So we're very glad they're concerned. And, you know,
we're not going to have him just sit in a room all the time to protect him from having seizures. We want him to experience life.
Right, absolutely. And that was a great example of getting his input and working together to come up with a decision on whether or not to do that ride. So
Exactly.
and other things besides the cognitive side of things, what other ways do you assist Mark on a day-to-day basis, and how did you kind of decide upon that level of assistance on a day-to-day basis with epilepsy self-management?
Did you mean Alex or Mark?
Hannah, I was with
sorry.
Mark, sorry.
Sorry, could you repeat that a little bit?
Yeah, just outside of the what you mentioned about cognitive function and assistance and reminders and guidance there, what other types of things with epilepsy self-management on a day-to-day basis do you assist with, and how did you and Mark come to a decision about where he wants assistance, where he doesn't? Okay,
yeah, that's a great question. Driving is one aspect and meds is another. So just tagging on what Nick and Joan were saying about how do you be parents of an adult child, right? So his parents helped, remind him of meds and to do different things like that if he would make med errors. And that used to be a problem, like med errors, but not so much anymore. We've finally figured out a way. I lived around him enough to recognize that if we label the bottles differently, and Mark came up with this too, but if we label the bottles differently, it makes a difference with his ability to be independent with that. So instead of saying 2 tabs twice a day, which you might think, oh, I need to take 1 in the morning, 1 at night, that's 2 tabs once in the, 2 times in the day. We asked, hey, can you say 2 tabs in the AM, 2 tabs in the PM? Solved the problem. And then he keeps, a med caddy or med reminder, sets him up himself, and really that's taking care of it. But as parents, I think before, it's just easy to fall into those patterns and to get used to whatever was his normal. So, driving is another one. That was a big one when we first got married because Mark drove for years, 18 years with seizures, because his seizures were nocturnal. They were based in his sleep cycle, and there was he also has congenital nystagmus. So that's another aspect. It's not necessarily related to seizures, but it is neurologically based. And he is able, or was able, to drive with that condition using a adaptive device. And now they don't allow, you can drive with that device, but not on freeways and not at night. But when he first got diagnosed with epilepsy and started on some medications, he drove on a day, it was actually just the first day of snow, and got in a car accident, just fender bender. But because of his congenital nystagmus, I feel like I'm kind of going off here a little bit. Anyway, he wasn't able to balance or walk, and the officer thought he wasn't well because he has a stammer, which is all related to seizures, and didn't understand what he was saying. So he was perceived as being much less, able to function. And unfortunately, that resulted in losing his license. So that's a long story to say we had to figure out driving because it was 1 year into our marriage that happened. So And I didn't want to drive him everywhere. I didn't want to be, I was happy to help, but I was like, you have to learn the bus system. And we had disagreements about that. So that was challenging. I don't know how we really came to a conclusion. We just kind of took it one day at a time. Really had to get over a loss. It was a huge loss. He hasn't driven in the last 5 or 6 years. But now that he knows that, I'm much more willing to provide rides, and we kind of just navigate. I don't know if that makes sense.
And he uses the Grand Rapids public transit system.
Yeah. Yes.
That really helps too, to have a good public transit system too. So
it does. The challenges were 20-minute walk away from the bus. It takes 45 minutes to go somewhere that takes 10 minutes to drive. It takes a 5-hour round trip to go across town for a 1-hour appointment. And if you're doing that in weather, because I'm at work, that's really a pain, even though we have that great system. So I don't mean to complain, but that's the reality.
Yeah, certainly that I know there's talk about infrastructure on the federal level. That would certainly be an area where we could improve. Dr. Tang, what are some of the most common problems that you encounter in terms of epilepsy self-management and the role that caregivers play in supporting that? And how do you kind of counsel patients and families to help them find that effective and agreeable level of caregiver involvement?
I think that Nick, Joan, and Hannah really hit a lot of the big parts of this. I work with patients at least until their 20s, even 30s and beyond. And even in the fully cognitively intact patients, I can end up working with them well into their adulthood to try to, a patient that should be independent, try to make them independent. Obviously, some of that can be cognitive disability, but often, it's partially due to some intimidation from the patient of trying to go out on their own in some cases and learn some lessons on their own, and take what they've learned from their caregiver, parent, spouse, and kind of use that to move forward. And then there, on the other side, on the caregiver side, sometimes it's easier and the caregiver feels a little safer not letting the patient push any boundaries. So like you guys said, learning what those boundaries should be, and then trying to let them learn a little bit, within a little bit of, trying to keep them safe, kind of behind the scenes. So yeah, from my standpoint, I try to determine how independent the patient can be safely, and then encourage the parents to allow some things based on that. And I try to stress as much as it's possible that allowing the patient to manage themselves independently as best as they can facilitate more self-care for the caregiver, and kind of in some ways reduce the stress of trying to be responsible 24/7. I know that's not always fully possible, but as best as we can. And it also lets the patient kind of develop some age-appropriate social behavior, social and professional relationships, getting a job, going to school.
Right. So it's a degree of finding what an acceptable level of risk you're willing to take, and trying to be okay with possible mistakes, as long as the consequences of those mistakes are not devastating. And so just finding that balance between safety and independence is a challenging thing, but I think as Hannah and Nick and Joan, they've all worked through that over the years to find that balance point. So it can take a significant amount of communication and oversight to support the safety of a loved one with epilepsy in the public and in various community settings like school or employment or in social activities. So Joan and Nick and Hannah, what are some of the steps that you've taken over the years to make sure that those who spend time with your family member with epilepsy are able to recognize seizures, respond appropriately, and adequately support their safety? And you've touched on this a little bit already, but any additional things that you haven't mentioned already?
I can jump in here. We've got a pretty unique experience, in that Mark and I have a 10 or 11-month-old now together, and so it was very concerning because about the time when I would go into labor and having Mark present as my support person and as a participant in the birth of our son. We really wanted him, both of us really wanted him to be able to be there. Now, sleep deprivation triggers seizures for him. And so he's not going to be able to pull a 24-hour shift. I'm not going to have that support potentially. We're imagining all these worst case scenarios, right? And then what if the nurse or nurses see him have a seizure, and let's say it's a bigger one, because we can't guarantee. What if he's in a different situation? The stress of it triggers, he falls out of the bed in the hospital and they send him to the ER, and we're during COVID. So he had to stay at the hospital overnight. He couldn't come and go either. So we didn't have that option. So we worried a lot about it and talked to his epileptologist, and and actually the Epilepsy Foundation too. I spoke with Renee quite a bit about it, possibly Russ. So we had a plan. I got a doula to have an extra support person when he was going to have planned time for sleep. We determined at what point to have him wake up, if, or to wake him despite his sleep, if I was just about to have the baby. Our epileptologist, Dr. Abbas from Spectrum, allowed us to have him on like speed dial if we needed anything or if the nurses had any questions. So we had a backup plan in support of the medical team, which was really great. And then Mark listed his medications on the board. I mean, they didn't have to know all his health information. It's not really their business. But we felt like if we educated the nurses about what his baseline seizures were, that this was a condition he'd had for a long time, that even if he had one, he's stable and that he didn't need to go to the ER, it was not a problem at all. Actually, our son Christopher was born at around 7 or 8 at night. So Mark we didn't even have to worry all that much. He was able to be part of it, cut the umbilical cord, and we are so happy about our little one. But yeah, parenting is a whole new avenue. And just kind of trying to figure out, I've been in touch with a couple other moms and wives of persons with epilepsy and who have kids, and just trying to figure out how do you teach your kids about seizures and different things like that. So that'll be interesting.
Right. Well, that's a great example. And Hannah, just to kind of follow up on that, what did you and Mark decide in terms of whether to use any kind of medical ID or for if he were to have a seizure in the public, or having a seizure action plan? Have you decided to use either of those things?
For Mark?
Yeah.
We have not actually. He does not have probably should. It's a good point. But his seizures are always during his sleep cycle, and that has been proven over and over and over with the data from the NeuroPace. Mm-hmm. So yep. It hasn't been necessary.
Right, makes sense. Yeah, Nick and Joan, what about you? How have you educated the places where Alex might spend time on seizure recognition and first aid and that type of thing?
Well, one of the things is Joan mentioned about educating people around you, and at school, I just recall, I'm at work, and then Joan would call me and said, Alex has had a seizure. I'm on my way to school. Initially, school would immediately call 911 in the ambulance before they would call Joan. And the next thing you know, she's going to the hospital to spend the 4 to 5 hours in there. What we told them is, for Alex, what we discovered is a cold compress to the forehead, cross his arms, and that would seem to minimize the time for the seizure. We had to educate all of those people around him to do that. And we asked them, please call Joan first because she could get to her within 5 minutes. And instead of, if the seizure was longer than 2 minutes, then go ahead and call the 911. And then they could take him to the hospital because we were going back and forth. So she was doing that regularly. And and after we informed them and educated them, they realized the seizures would stop. Joan would show up. She could bring him home. And instead of spending 4 hours in a hospital, emergency room, he could rest and recuperate at the house. Similarly, like playing basketball, one of the things Alex wanted to do because his brothers and sisters did that, we had to educate him that he can't get worked up, but he could still participate by giving him the ball and letting him shoot that ball, without having to run up and down the court, back and forth, or get bumped, that kind of thing. So again, you just got to let people know about what his limitations are so that to prevent that seizure from happening.
Well, and to back that up a bit, call 911 if you're not comfortable, his caregivers, my family, because you know what? Emergency help is on, it's going to help them. And what do we want in that moment? We need help for them. And then I'd arrive on the scene, and often if I felt like I could just take him home and take care of him, then I would just sign off. But no, it is important to educate everyone from his bus drivers to his teachers to whoever he's going to be in contact with. I made up little cards with emergency numbers. He'd have a new bus driver, and I would take 5 minutes in the morning in the driveway just saying, you know what, watch Alex walk off the bus. One time I didn't, and he walked off the bus into he's in a sheltered workshop program now. Well, because of COVID, he's not, but and he slipped on a patch of ice and went down. He wears a soft shelled helmet. So it's like, put that helmet on him before he gets off, aid him. It's just about educating everyone from the bus driver to his doctors, to his grandmother, to, the cousin.
One example of, and obviously since we experienced those seizures and we knew what to do, a friend of one of my daughters was at the house and he had a seizure, and it was the first time she ever saw that. And she just said it was amazing how calm everyone was, yet she was in a panic because of what was happening to Alex. And again, we educated her afterwards. This is what happens, and this is how. And it's not that he's, in grave danger, but we want to make sure he's not going to get hurt when he has that seizure.
Right. So yeah, really the power of education and just simply letting people know what your preferences are in terms of seizure management and seizure response. And once you get past that initial fear factor, I think most people are able to provide that necessary support. So, Dr. Tang, we were mentioning seizure action plans. Seizure action plans and rescue medications are commonly used for children with epilepsy, but I get the sense that they're much less common among adults. Are you seeing any trends among epileptologists toward increased use of seizure action plans and rescue medications in adults to help promote increased independence and community participation?
Well, I think I saw a recent study that showed only about 30% of adult patients have a seizure action plan. So you're correct, it's primarily used in children. I think in children, they said it was about 45%. So children in schools and adults in managed care facilities seem to be the majority. I think some of this is partially because schools in these facilities tend to require them, and they, some of what the bulk of these documents tend to account for legal concerns that the facility might have in terms of administering things safely. For most other people, I would say there hasn't been too much of a push for a formal action plan, but there is a push to have at least an informal set of recommendations. And a lot of these sets of recommendations for the patient care in an acute situation are like what the other panelists have mentioned, and even some of the guests have been mentioning in the chat. It's to educate the people around the patient of what to do, especially if the caregiver can't make it. Either maybe the caregiver's sick, you can't say for sure. So, and I've seen some people writing in the message board, they have like laminated note cards. And something like that is great, and things you can put on that are, What's the best way to position the patient during a seizure? How do you monitor a patient during a seizure without, doing too much to hurt them? When should you call 911, or when should you just call the caregiver or the clinic? Other things to include, I think, are important would be, important facts that EMS might want to know, or the hospital might want to know, like what are the current medications and doses? What's worked in the past for a cluster of seizures or status? And again, all the contact information that's relevant, and not just primary caregiver, but secondary people that might know something. And you can give this to, again, other non-primary caregivers, close friends, frequent contacts, people at work, school, and just something that's kept on the patient at all times. So again, in adults and most people, it's not really a formal thing. It's not a formal, like, 5-page document that's signed by the doctor. It's usually something you create on your own. In terms of rescue medications, I think that there are some big pros and cons to these, which is why I don't, and I know most of my colleagues don't, prescribe them to everybody. They certainly can help prevent, progression of one seizure to status epilepticus or to a cluster of seizures and frequent ER visits. But, the big downside is that they can, the patient and the caregiver have to demonstrate that they can use them safely. And a lot of people don't realize that, you can't stuff a pill in someone who's actively seizing's mouth. And trying to teach them that. If also given too much, without knowing when to stop and call 911, it can lead to a lot of dangerous sedation, respiratory depression, things like that. So I had to pick and choose my patients very carefully who I give rescue medications, rather than telling them to call 911. Additionally, some employers don't really have the resources. Some of these smaller employees don't have the resources to actually act with one of these rescue medications. The good thing is we have newer ones coming up. We have the Nasolam, which takes it a little easier than things like rectal diastat of the old days.
Obviously, yeah. So a wide range of health and human services may be required to support individuals with epilepsy, and the number of supports needed typically increases with the severity of the epilepsy. Caregivers often need to navigate complex and often disjointed systems, including health insurance and school systems and vocational rehabilitation, community mental health, social security, respite care, residential or long-term care systems, and much more. So Hannah and Joan and Nick, can each of you talk about some of the biggest challenges you've faced in terms of accessing and coordinating these services, and some strategies or resources that might be able to help?
Well, obviously, when Alex turned 18, that was a milestone, and because of his being cognitively impaired, and again, through the agencies, whether it's through Epilepsy Foundation of Michigan or the ARC, the resources are there to help navigate that. He had to apply for Social Security. We had him apply for Social Security, so we had the aid there, and Medicaid. But also I found out I had to type up a letter and provide the documentation to my work so that he could continue on our medical plan after the age of 26. So it's coordinated care between my health care as well as Medicaid then for him. So you, through those agencies, and you start to learn and have that help to navigate through that.
It's been challenging, I'll say, navigating, especially the school systems, because in Michigan, there's school till age 25, and there weren't a lot of resources back when Alex was, 5-10 years ago. What do we do next? So I kind of just jumped on the bandwagon and started a parent support group. And what we did is, with other parents that have been in this, we found out what's available next. What is he going to do from age 25 to 95, and then just going and looking at programs. And so we had a parent group. There were probably 10 moms couple of dads, and we would just go look at these programs and saying, you know, some parents, they want their kid in the community and out walking. For Alex, we needed him in a sheltered workshop where he knew, you know, we live in Michigan. He has to be safe during the winter. He can't be out in the, you know, snow and ice and whatever. So it's about doing your homework and researching, seeing what's available, talking to other caregivers, parents, other agencies such as Nick mentioned, you know, the ARC, the Epilepsy Foundation of Michigan, and, you know, brainstorming together and trying to find the best fit for your child, because again, you're his best advocate.
Right. That, I mean, that makes a lot of sense. There's so much you can learn from other parents and other families in their efforts to navigate these systems. What has worked well for them, what hasn't, what are some of the stumbling blocks. So
well, and Russ, on that note, you know, like the school system he was in, I would talk to the counselors and saying, you need to have some kind of program to show these parents how to transition to the next step for our children. So it's communication. Yeah, you're right, you know.
Right, and with special education, transition planning is a fundamental part of that, but a lot of parents are never informed that transition planning is part of an IEP, and you know, or they're not really actively involved in that, or invited to be actively involved. So that's, you know, another thing that parents can be aware of is if your child has an IEP, transition planning is a fundamental part of that. So Hannah, any things that you've learned from trying to navigate different health and human services?
Yeah, so I can tell you a little bit about the challenges in navigating and accessing them. One piece that has actually been an asset for Mark and I is that I'm a social worker. And so I've had experience with case management and helping people to access various community organizations. And so that's right up my alley, and it's in my wheelhouse. So that's great. I also am a very detailed person. And so I like to know, you know, all of everything. And so, yeah, that's helped with access, I would say. Vocational rehabilitation is one of the things that I think about with the Michigan Rehabilitation Services, or MRS, here in Grand Rapids that Mark has accessed. I think the challenge around utilizing the services for us as a couple has been where I'm trying to not intervene too much. So like it's a balance between, like, they say, oh, well, let's look at, well, Mark has shown interest in working with animals, and he's shown interest in working with children, and he's currently working in our building services at church. And so, and he's done that sort of work and has experience in that for several years, but sometimes kind of gets bored and, you know, like, let's try to do something more. I'm an extrovert, he says, and, you know, I want to do something different. So it's challenging to know how to participate, or if to participate in that, especially being that I know how to navigate the system, but not saying too much, you know, and letting him make those decisions, like, yeah, I'm going to pursue this, or no, I'm not going to pursue this. And so that can be kind of tricky. It's a little different take on that question, though. Another area of access to care is medications. It's not as much of a service as it is a necessity. And I've been the primary, we both work, but I've been the primary breadwinner in I have the insurance policy. And for a while, Mark had disability closer to that seizure time, the surgery, excuse me. And so he also had Medicare. So I was tasked primarily, and I don't mind, but with coordinating with prior authorizations for medications, working with insurance companies around med limits, because Merck's on 4 different medications, and I swear all of them are either not in the formulary or the amount is not in the formulary or whatever. And so the insurance companies don't want to pay for it. So we have to jump through hoops. And then in my field, I've also been working from, getting my master's to being a limited licensed social worker to a fully licensed. And so I have switched positions, as many do, as they move in that field. And so that has resulted in periods of no job as I'm searching, or changes in insurance. And then I've worked at a small place, and so that a smaller organization, and that makes one insurance primary and not the other, as would be different if you're at a larger organization. There's all these like loopholes and forms to fill out to try to get reimbursed. So what would be helpful for other caregivers if they are trying to navigate that? I would say keep a running journal or diary of the conversations you have with people. I have kept first names and initials, and then I ask for a tracking number for the phone call. I write the date, and then I ask them to slowly explain in what I call insurance language what it is that they are committing to do and when I can get back to them, or when they plan to get back to me. So then I can call back if I hear nothing and say, hey, I spoke with Joe, reference number, and it's like 12 digits, and that has been much more effective, particularly the wording of however they say it, because inevitably I'll explain it the way I hear it and they don't know what I'm talking about, and you get whatever the next customer service rep in the queue is. So it's challenging.
Yeah, and that's, it is a shame that that health insurance and just simply getting your medications covered is so complex and unnecessarily complex. Dr. Tang, what are some of the perhaps underutilized services and professionals that caregivers can access within hospitals and health systems and epilepsy centers to kind of help them access and coordinate community-based services, and also to help with things like insurance issues like Hannah was referring to?
Well, we do use our social workers quite extensively to help with this, because a lot of us doctors, we learn the medicine, but we don't really learn a lot of the other navigation through the system. So, they help us a lot. And some of even our nurses in clinic know a lot about navigating through, the financial aspect of things. Other than that, in terms of finances, doctors do occasionally meet with pharmaceutical representatives. People think it's for fun and like dinner, but we do spend a lot of the time meeting with them to help them or convince them to give us, ways to help finance their medications, and especially the expensive ones. And so we can use that to give the patient and caregivers information on that when it's available. So you can always ask your doctor if you're on one of those more expensive medications, is there something that you can do, or something I can do, some paperwork to help out with this. Other things, there are a lot of specialists, that we work with within our hospitals. For example, people who are on or interested in the ketogenic diet or diet-controlled epilepsy, a lot of hospitals will have a dietitian that can give them some professional tips on that. Some centers will even have a neurologist, an epileptologist who actually specializes in ketogenic diets. You can get some even more information, make sure you're doing it safely. If your patient needs, physical or occupational therapy, you can certainly ask for that. Psychiatric and counseling services are available. People who have, comorbid mood disorders or behavioral problems. We also work with palliative care for people who have kind of advanced epilepsy and might need some planning help. That being said, I do think most of the resources are found in the community setting, such as on the Michigan Epilepsy Foundation websites. And, in terms of that, we primarily let the patients know these resources exist, and they kind of go out and look on their own for those things. You know, I did want to mention here that we focus on the patient themselves a lot, and, you know, treating them, fixing their epilepsy, but there has to be some focus on the caregiver's well-being as well. And I think that some of the social resources on websites like this, the Epilepsy Foundation website, can be helpful for that. Things like epilepsy strolls. We have a painting group here, at least before COVID started. And it helps caregivers and even patients, you know, meet other people in the epilepsy community who understand some of the problems that you might be having. And maybe you could socialize with them without having to explain yourself as much. So just thinking about like your mental and physical health is also very important. You know, I have become interested in some of the respite resources. I don't have too much background in that, especially within Michigan, but you know, that's another resource that I think is more important. And if anyone knows more about that, I'd definitely be interested.
Great. So given the time, I did have a few more questions, but I want to make sure we get to the questions from the audience. So I'm going to open these up and we'll see if we can address some of these. A question about psychogenic non-epileptic seizures, and maybe Dr. Tang, you can talk about any unique challenges from a caregiver perspective in helping someone who has psychogenic non-epileptic seizures.
I think one of the biggest challenges with non-epileptic seizures is they can often be comorbid or exist with a true epilepsy. And that makes it extremely hard to manage in some cases, especially when it's new to the patient. One of the big challenges is determining what is a psychogenic seizure and what is an epileptic seizure, and not overtreating the psychogenic seizures, because that's a big cause of morbidity, mortality in these patients. They get, you know, they end up being given Ativan or these rescue meds until they're completely sedated. They end up intubated. And it's not until we get an EEG started, if that's even available. So, you know, a big part of it is educating the people around you about, you know, your condition, and not feeling bad about it. You know, it's not your fault that you have it. It's the way your brain is expressing, you know, things that are going on or have gone on around you.
Great, thank you. And Nick and Joan, do you have arrangements for care for your son after both of you are gone? And that was actually one of my questions that I didn't get to, is planning for the future. And that's obviously, it's a very common concern among caregivers, is who will take care of my loved one when we're gone.
So, as I mentioned, through the ARC, they had the After I'm Gone program, which educated us on, you know, the special needs trust, and that's what we ended up doing, putting together a special need trust for Alex. And we are fortunate that he has 3 other brothers and sisters that are willing and want to help take care of him. Our plan was that we're going to take care of him as long as we are physically and mentally ourselves capable to do that. And our children have stepped up and said that they don't want Alex, you know, living in a facility. They would like to take care of him after we're gone, I'll say. So we've got that in place. We've got, as I mentioned, the power of attorneys and the documentation in place, so that would be a seamless transition as we move on to our next phase in life.
Okay, and actually, as a follow-up to that, someone else asked about ARC, about the ARC, and can you share a little bit more about that, and when did you contact them for Alex? Just to kind of give people a background, ARC is an organization. There's ARC of Michigan, which is a statewide organization that does primarily public policy sort of work. but then there's also local ARC offices and regional ARC offices. So, and every region has an ARC within a certain geographic distance. So can you talk a little bit about what the services you've received, how you found out about them, how you connected with them?
Sure. So Alex participated in a special needs program, education program in Livonia Public Schools. We actually lived in the Plymouth Canton Public Schools. When we came back from New Jersey, he was in a special education school called Rockbrook, which was entirely special education children. When we came back, I investigated both in Northville, Plymouth Canton, and in the Livonia area. And actually it was, I can't remember, the superintendent in Canton had actually recommended the Livonia system because they had a school called Webster, which was gifted children and special needs children. And through that special education program, Alex brought home one day through the flyer, and I'm trying to remember, he would have probably been around 10, 12 years old at the time, between 10 and 12, that they had, the ARC was available, and they had different programs or informational programs for children of special needs, and one of them was called the After I'm Gone program. So it was 5, 6 o'clock at night, they would do that for the parents, and you participate, and you go there, and they had at the time a lawyer that was talking about special needs trusts and talking about Social Security and some of the things, the mental health agencies that are available and the services that are there. And that's how I became involved in it. There's one in Western Wayne County. I think there's also one in Detroit. Like you mentioned, there's several of them, but the Western Wayne County was nearest to us. And I connected with the director at the ARC there, and she was very helpful, very beneficial. And that's where we put a plan together of what Alex. She would sit down and talk to Alex. What do you want to do later in life? And he explained what his needs and desires were. And that's where we connected them with a lawyer that put the special needs trust together for us, that type of thing. And obviously with my financial planner, we connect with that lawyer also. So there's coordination between that. So, but yeah,
great source of information.
Yeah, exactly.
Yeah.
Right. And their focus, I forgot to mention this, their focus is on people with intellectual and developmental disabilities. So
exactly. Yeah.
And then Dr. Tang, maybe you can speak to this. How often should seizure action plans be reviewed or updated?
I would say it could be reviewed at least once a year, unless the epilepsy is, if the epilepsy is stable. If things are ever changing, it might be worth just taking a quick look at it every time you see the patient. So maybe more than that, every 6 months, if you're changing meds a lot.
Okay, great. Well, we've answered all the questions. So with the remaining time, if anyone has any kind of closing thoughts that you'd like to share or just words of encouragement or suggestions for our audience that you'd like to share before we wrap this up. Hannah, did you have anything you wanted to share?
I'm glad that I was able to be here today, and just want to encourage those who are doing caregiving or to keep up the good work, to not be afraid to ask for support and help, and then for those who are and then I think maybe particularly for parents or those who have a little bit higher functioning, as Mark is, I would say, as much as you're able to balance providing autonomy versus being protective, especially in that transition to adulthood, I think that's incredibly important. I know that's not so much of a closing remark, but it's just, I think it's a really important thing for those who are able to get life skills and to be able to live independently, Yeah, so it's a hard balance, I guess. Whether it's a parent of someone with epilepsy or a spouse of someone with epilepsy, to figure out what those appropriate boundaries are, what those lines are for safety. And communication is probably the biggest part of that will facilitate a healthy relationship and a good working relationship in trying to access services and supports. And just being able to live a really fulfilled life in whatever way that might look like for you.
Great. Thank you, Hannah. Dr. Tang, any closing thoughts you'd like to share?
You know, like most of the people today have probably figured out, I think the doctor in epilepsy is only one small piece of treating the epilepsy, and these community resources and the communication between everyone is very important, and quality of life, and trying to balance things for quality of life is all just as important at sometimes as finding the perfect medication.
Thank you. And Nick and Joan, any last thoughts?
Well, first, I just want to thank you, Russ, for inviting us to be part of this today. I mean, the Epilepsy Foundation of Michigan does great work, and really appreciate that we're able to participate in this.
Right, and just to all the people out there, just know help is out there. It's available. Sometimes we don't know where to go to find it, but ask a lot of questions. Ask your neurologist. Call the Epilepsy Foundation. Google. I mean, I Google things, you know. Talk to other parents, because we're the best advocate for our loved ones, and obviously we want the best care for them. And we're the ones that are going to find it. So if you're really searching, just ask. If the Epilepsy Foundation doesn't know, they'll send you to someone else. You know, ask a lot of questions of your healthcare worker, your school system, because help is available. And if you want the best care for your loved one, as we all do, ask the questions and do your homework. You know, it's a lot of work, but it's worth it. Yeah.
Great parting words. So thank you all for such a rich and informative discussion. So I really appreciate that.